Good morning, everyone. It's my pleasure to welcome you all, both physically and virtually, to the month of April Young Physicians Forum and college, which will be followed by the college lecture. To start with the proceedings, I would like to invite Dr. S.W. Janatha, Senior Registrar in Endocrinology, National Hospital, Sri Lanka, to talk to us about osteoporosis, the battle to be won. Over to you, Dr. Janatha.
Good afternoon. Good afternoon. Thank you, sir, for the kind introduction. And I would like to thank Ceylon College of Physicians for this wonderful opportunity given to me to present here on osteoporosis, the battle to be won. I would like to start the presentation with a quote by Dr. Miller saying that osteoporosis is for those of us devoted to abolishing this disease, the battle being lost on many faces of many hills. What is osteoporosis? It is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. The fragility fracture means a fracture which is sustained with a force similar to a fall from a standing height or less than that. If I quickly go through the pathophysiology of osteoporosis in related to the bone mass, the peak bone mass in both the males and females is achieved by the age of 30 years, and until the 40 to 50 years, it is maintained. And especially in females at menopause, there is dramatic loss in the bone mineral density and followed by age-dependent gradual loss in the bone mineral density, which occurs in both the males and females. Osteoporosis is an enormous burden worldwide because in people more than 50 years, 1 in 3 women and 1 in 5 men will break a bone due to osteoporosis. Here I would like to highlight that osteoporosis is no longer the disease only for females, and in men it is most of the time underdiagnosed and undertreated. In addition, more than 8.9 million fractures occurring annually, accounting for 1 fracture occurring every 3 seconds. And in regard to hip fracture incidence, it has been postulated a great rise in the fracture incidence of more than 3 falls in men and more than 2 falls in women from 1990 to 2050. In addition to being as an enormous burden, osteoporosis is a silent killer because in most of the patients exhibit no symptoms until they develop a significant fracture. But it can cause significant height loss with a stooped posture, dependence, disability, and reduced quality of life. Other than that, 1/3 of hip fracture patients are totally dependent and 1/4 of them die during the first year after the fracture. So it significantly increases the mortality rate. So though it is an enormous burden and a silent killer, it is very much underdiagnosed and undertreated, unfortunately. You can obviously see that only 1/3 of vertebral fractures come to clinical attention, and 80% of people who have had at least 1 osteoporotic fracture are neither identified nor treated for osteoporosis. Why is that? The major reasons are limitation of the facilities to measure the bone mineral density, unawareness of the fracture risk assessment methods, under-appreciation of the seriousness of this problem, and the fear of safety of bisphosphonates. And it is fundamentally very important for the secondary fracture prevention, because more than 50% of people with one osteoporotic fracture will have another one soon after the first fracture. And this fracture is very high and imminent during the first 2 years. That's why when a patient presents to us with a fracture, in addition to intervening that particular fracture, especially the surgical intervention, it is further more important to evaluate for osteoporosis and treat that to stop with that one fracture rather than developing more fractures. Now, if I can take you all through the journey of Mrs. X, she is a 63-year-old postmenopausal woman being treated for type 2 diabetes over the last 10 years, comes to you, and she is very much concerned whether she will develop a fracture in the future, because her friend had a hip fracture recently and she had become completely dependent. So what should be done to this lady? All postmenopausal women and men aged 50 years or more should undergo clinical fracture risk assessment to determine the need for BMD assessment and further evaluation. So the clinical risk assessment should include history and examination, including prior fracture without any major trauma, other clinical risk factors such as smoking, early menopause, low body weight, and excess alcohol intake, and any clinical evidence of secondary osteoporosis, height loss or kyphosis, risk factor for falls, family history of fractures, and being on long-term glucocorticoid therapy. If we can see the causes of secondary osteoporosis, it is an exhausting list. If we can see 30% of postmenopausal women has some secondary risk factor for the osteoporosis. And the most common cause for the secondary osteoporosis is glucocorticoids, followed by endocrine and gastrointestinal causes, such as hyperparathyroidism, hypogonadism, and mainly gastrointestinal malabsorptive conditions. So here, Mrs. X, the initial clinical assessment revealed she has few risk factors, such as she attained menopause at the age of 41. Her mother had a hip fracture, and she has a very low BMI of 17.6. So what to do next? The BMD assessment, especially with the DEXA scan in our settings, is indicated in women aged 65 years or more and men aged 70 years or more, regardless of the presence of clinical risk factors. But in younger postmenopausal women and men aged 50 to 69 years, with the presence of clinical risk factors, and adults who have had a fracture at the age of 50 years or older, and in adults with the causes of secondary osteoporosis. Our patient, Mrs. X, falls into this category and undergoes the BMD assessment with the DEXA scan. The DEXA scan, which is the dual energy geometry, is the widely used method among the various available methods such as quantitative CT and ultrasound, which are not available in our setup. And in the DEXA scan, it most commonly includes a scan of the lumbar spine and hip. Measurement of forearm is indicated in special circumstances where the hip and the spine can't be positioned properly because of some fracture or some other reason, or in patients with primary hyperparathyroidism, where the cortex is affected than the trabecular bone. So this is the BMD criteria proposed by WHO in 1994, which indicates the BMD T-score. If it is less than -2.5, it indicates osteoporosis, and osteopenia if it is between -1 to -2.5. So DEXA scan interpretation is very important. Before going into the values of first of all, we have to check for the proper positioning of the spine and the hip, and to look for any obvious focal areas of increased or reduced bone density of a particular region, which might underestimate or low estimate the problem. So Mrs. X come with a scan, DEXA scan report, and the diagnostic categorization of the osteoporosis is according to the T-score. The lowest T-score should be identified among the lumbar spine and the hip. And if you see in the lumbar region, the total of the L1 to L4 T-score should be considered unless any focal artifacts requiring the exclusion of that particular vertebra. Among the hip, the lowest among the neck and the total should be considered. So overall, if we can see, the lowest value is here at the neck, which is minus 2.3, indicating that Mrs. X has osteopenia according to BMD-based classification. So before going into the Mrs. X management, I would like to tell you something regarding the relevance of Z score. In compared to T-score, which is the number of standard deviations from the normal young adult mean values, Z-score is the number of standard deviations from the normal mean value for the age, ethnicity, and sex-matched control subjects. It is mainly recommended for premenopausal women and men less than 50 years. And if the Z-score is minus 2 or less than that, it is defined as below the expected range for age, and those patients should be thoroughly evaluated for the causes of secondary osteoporosis. Even it has some clinical relevance is postmenopausal women and elderly males. With the diagnosis of the osteoporosis, according to the T-score, if the Z-score is less than minus 2, it indicates the probable presence of secondary osteoporosis, and they should undergo comprehensive evaluation. So this is the fundamental problem in the evaluation and management of osteoporosis. If you can see, only small number of patients develop the fractures with the BMD being in the osteoporotic range. According to the current evidence, more than 80% of the fractures occur in patients with their BMD in the osteopenic range. Here again, you can see the number of fractures are higher in the osteopenic range BMDs in compared to the osteoporotic range, although when the T-score is lower, the fracture rate is higher. So this is mainly because that is why the risk stratification on the basis of T-score alone is completely insufficient. This is mainly because of the presence of multiple bone mineral density independent risk factors for the osteoporosis, such as age, family and the past history of fracture, low BMI, alcohol intake, smoking, steroids use, fall risk, and rheumatoid arthritis. So here you can see, so in the patient, this particular T-score of minus 2.5, when the age increases, the 10-year fracture probability increases very significantly. So what is the solution for this? As a great solution for this, WHO collaboration with the Sheffield introduced the FRAX assessment tool in 2008, and which is the major success in the management of osteoporosis. So this FRAX is the online assessment tool specific to country and the gender, and it can be applied to people, men and women aged 40 to 90 years, and which works with and without BMD. And to highlight here, the output of the FRAX is the absolute risk of the fracture in compared to the relative risk when considering the bone mineral density alone. And the risk factors included in this FRAX tool are most of the BMD independent risk factors in the dichotomous manner, which is yes or no, and in the continuous manner, age and the BMI are being included. In addition to that, the optional input is the bone mineral density of the femoral neck. So the FRAX assessment tool can be accessed through this Sheffield website, and we can select our country. Our country has its own FRAX model, and most of the countries has a validated FRAX model. So FRAX was applied to our patient, Mrs. X, and it indicates she has 10-year probability fracture, or probability of major osteoporotic fracture is 9.5%. Now, major osteoporotic fracture includes hip, clinical spine, wrist, and the humerus fractures. If that is so, what is the risk threshold to decide on treatment, which is the intervention? So here you can see in otherwise matched people from different countries, this graph beautifully depicts that there is significant difference in the 10-year fracture probability between the countries, indicating the requirement for the country-specific intervention thresholds. So in that regard, because of due to the great work by Professor Sarath Lekam, we have our own Sri Lankan country-specific thresholds, which has been even revised recently in 2019, which indicates the 9% threshold for the major osteoporotic fracture to intervene, and for the hip fracture, it is 3%. So the intervention means not only the osteoporosis specific pharmacotherapy, but also the evaluation and treatment for the secondary causes. So, are there any limitations of the FRAX tool? Unfortunately, yes, because it may underestimate the risk of fracture in patients with diabetes. Studies have proven in diabetes, the fracture risk is increased in the BMD independent manner. Other than that, frequent falls, parental history of non-hip fracture, because in the FRAX input, the included one is only the parental history of hip fracture and the recent fracture. And it does not take into account of dose-response relationships, especially in case of glucocorticoids, smoking, and number and the severity of the previous fracture history is also not considered. For example, if we have two patients, with the one patient who had only one fracture in the past without any significant disability, and other patient, she had two fractures with significant disability, in the FRAX tool, both have the same inputs, and is only intended for use in treatment-naive patients. So there is an ongoing controversy whether we can use this for the reassessment of patients being on treated for osteoporosis to reassess the fracture risk. And utility is dependent on chosen thresholds for intervention. As I mentioned earlier, we have our own country-specific thresholds, but some countries does not have. So if any country uses the threshold blindly from the international guidelines, they will be overtreat or undertreat their patients. That's why here you can see a list of risk factors such as diabetes, fall history, and recent fracture. All these are again the BMT independent risk factors which have not been included in the current FRAX. But for all of these risk factors, there has been multiple ways of adjustment of the FRAX. For example, in type 2 diabetes, there is 4 adjustment methods such as entering years in the rheumatoid arthritis. But the thing is, when we have adjusted again and again, the accuracy of the real FRAX reduces, and there is evolving data that type 2 diabetes, recurrent falls, and recent fracture very much increases the fracture risk, but unfortunately these are not included in the current FRAX tool. That's why there is a rethinking going on, in preparation of the second generation FRAX, but which will have its own limitations. So FRAX adjustment was done for type 2 diabetes in our patient. Her major osteoporotic risk rises from 9.5% to 13%. Now, if I take you through how the diagnosis of osteoporosis in postmenopausal women and men more than 50 years is made. First, as we all know, according to the BMD criteria, when the T-score is less than -2.5. In addition to that, according to clinical criteria, diagnosis of osteoporosis can be made in the following 3 situations. One is low trauma spine or hip fracture, regardless of the bone mineral density, and T-score in the osteopenic range, and a fragility fracture of other areas like proximal humerus, pelvis, or the distal forearm, and the T-score in the osteopenic range with a fracture probability more than the country-specific thresholds. So Mrs. X, our patient, falls into this category and being diagnosed with osteoporosis. So what can we do if DEXA facility is not available? Because DEXA facility is very much limited in the government sector in our country. There are 2 possible solutions, FRAX without BMT input and the vertebral fracture risk assessment. For example, if I may show the FRAX value without BMT input in our patient, it indicates the major osteoporotic risk is 15%. With the BMT input, it was 13%. Again, the studies have proven that FRAX works in similar manner in most of the patients with and without BMD input. And here, the National Osteoporosis guideline group in United Kingdom has introduced this lower assessment threshold and the upper assessment threshold in compared to the intervention threshold I was talking about before as a cost-effective method for the diagnosis and treatment of osteoporosis. If I explain you, all the patients, postmenopausal ladies and the men more than 50 years should undergo FRAX assessment without the BMD input. If their fracture probability falls into this low risk category, they neither need the BMD assessment nor the treatment. They should be advised on universal bone health measures. And if their fracture probability is more than the upper assessment threshold, they should be started on osteoporosis specific treatment after excluding the causes of secondary osteoporosis without the BMD measurement. But it is preferable to do the BMD measurement if it is possible, because that will be useful for the future monitoring during the follow-up of this patient. Considering this beautiful cost-effective fact, our country, Sri Lanka, also has, this is the latest article published last year, we also have our own age-dependent assessment thresholds in addition to the intervention thresholds as well for the major osteoporotic fracture and hip fracture. So we also can apply this, and according to this article, following this method, reduce the requirement of the DEXA scan by more than 30%. So the next solution is the vertebral fracture risk assessment. Considering the fact that vertebral fracture in an adult aged 50 years or more is diagnostic of osteoporosis, so when we are not provided with the facility of DEXA, if a woman comes and complains of back pain or the fracture of the vertebra is identified during another imaging done for another purposes, they can be considered to be started on treatment for the osteoporosis. After the diagnosis of osteoporosis is made, lab investigation should be done to exclude the causes of osteoporosis. Universal bone health measures should be advised. Osteoporosis-specific pharmacotherapy should be initiated, and the risk of fracture should be communicated with the patient and the long-term follow-up. And the lab investigations, all patients should undergo the following investigations, including the calcium profile, renal function, and vitamin D level. And only in selected patients, if clinically indicated, they should undergo other investigations. So Mrs. X had normal investigations except vitamin D deficiency. The universal bone health measures are not only recommended for the diagnosed patient with osteoporosis, all the people should follow this, and especially the postmenopausal ladies and men more than 50 years, despite the diagnosis of osteoporosis. This includes adequate intake of the calcium and vitamin D, cessation of smoking, avoidance of excess alcohol intake, regular exercise, and reduction of the falls. Adequate intake of calcium, combined dietary and supplemental calcium of 1,000 to 1,200 milligrams per day is the recommended one. And vitamin D deficiency, if it is present, it should be corrected, followed by the maintenance therapy of 1,000 to 2,000 international units per day. And regular weight bearing, muscle strengthening, and balance training exercises should be advised to the patient. And when we come to the osteoporosis specific pharmacotherapy, we have a lot of classes of FDA approved, very effective medications in the fracture risk reduction, such as bisphosphonates and denosumab, the anti-resorptive agents, and the teriparatide and romosozumab are the newer anabolic agents. And according to the availability, we are provided with the alendronate and zoledronate in the bisphosphonate group, and those are the first-line medications worldwide as well. And the selecting drugs should be according to the fracture risk. For example, if a patient have the very high fracture risk indicated by having a fracture in the recent 1 or 2 years, very low T-scores less than -3, and very high fracture probability, they should be preferably started on a parenteral medication such as IV zoledronate, IV zoledronic acid, or anabolic agents. And other patients without very high fracture risk can be started on alendronate or other medications according to the availability. So our patient Mrs. X, after the diagnosis of osteoporosis is made, vitamin D deficiency was corrected, followed by the maintenance therapy. Calcium carbonate was initiated, advised on exercises, and as the osteoporosis specific therapy, alendronate 70 milligram weekly was initiated. And to highlight here, her fracture risk was explained to her in a way that saying, among 100 people like you over the next 10 years, 13 will break a bone and 87 will not. This is not only applied to the fracture risk, but also in other risk assessment in medicine, such as cardiovascular risk. There has been enough evidence to say that rather than explaining in percentages and others, explaining in figures like this will improve the compliance of the patient. And the bisphosphonate holiday, this is again a fantastic thing in the osteoporosis. The rationale for the bisphosphonate holiday is mainly three. Because even after the withdrawal of the bisphosphonate therapy, especially in case of alendronate and zoledronate, the effects, the anti-resorptive effect is retained up to 5 years. And the second reason is, with the long-term treatment, there are some reported serious side effects, such as atypical femur fracture. And bisphosphonate holiday. So when the patient is on treatment, the fracture risk reassessment should be considered at 5 years for alendronate and 3 years for zoledronic acid. If the patient has persistent high risk, such as if the patient has persistent t-score less than -2.5, or if she or he has developed a fracture and so on, they can be continued on alendronate up to 10 years or zoledronate up to 6 years without the first bisphosphonate holiday. In the absence of these risk factors, they can be considered for the bisphosphonate holiday after proper communication with the patient. But to highlight here, they should be completely reassessed and they can't be discharged from us. And the drug holiday is not recommended for any other osteoporosis medications other than these. So before this 3 to 5 years of proper reassessment, how we are going to how we have to monitor these patients. At least annual monitoring of clinical assessment with the symptoms, height loss, and compliance is important. And serial BMT measurement is a controversial issue between the different international guidelines. But in resource-limited countries like Sri Lanka, DEXA can be repeated before 3 to 5 years only if there is persistent symptoms like back pain, height loss, suspected poor adherence, or new fracture while on treatment. And to highlight here, failure to therapy in the osteoporosis management is mainly due to poor adherence and presence of secondary osteoporosis, but not due to the drug failure. And the atypical femur fracture and osteonecrosis of jaw are very rare side effects. That's why benefit versus risk assessment is the core of the management. If you can see here, when 1,000 patients are being treated for the osteoporosis, we can prevent 10 fractures. But with a particular number of treatment, only very rare incidents of atypical femur fracture occurs. So Mrs. X, she was clinically assessed annually. She was asymptomatic throughout and she didn't develop any fractures. And the repeat DEXA was done only after 5 years of the completion of alendronate. And the fracture risk was reassessed. She didn't have any features of high risk. And there was improvement in the BMD. And now she is in holiday for the bisphosphonates, awaiting the reassessment in 3 years' time. With this, I would like to tell you some messages to take home that osteoporosis is very much underdiagnosed and undertreated. Most fractures occur in the osteopenic patients, so absolute risk assessment with FRAX is indicated. Untreated osteoporosis leads to vicious cycle of recurrent fractures. Osteoporosis can be effectively treated with prompt initiation of treatment, and continuous monitoring is essential part of management. Other than it, overall, all healthcare professionals treating adults for any other diseases should take the responsibility to win this battle in osteoporosis. Thank you. And here I would like to take the opportunity to thank my current trainers, Dr. Udita Bulugahapitiya, Dr. Manu Kasumanatilaka, and Dr. Sivadashya Padmanathan, and my pre-MD trainer, Dr. Perananda Raja. Thank you.
Thank you, Dr. for that presentation. We have time for one question.
You rightly said that the availability of Alexa scan is significant. How many hospitals do have Alexa scan? Goal has two.
Yes.
One is the
In the National Hospital and mainly in the Karapitiya Hospital, sir. And now recently it has been introduced in Teaching Hospital, Jaffna as well, sir.
Thank you very much. And with the time factor, we'll move on to the take up the certificate of compensation.